Welcome, everyone. This is Troy Logan from Proconex. For today's webinar, we will be discussing ATMP capacity through modeling and adaptive scheduling. Today, I'm pleased to introduce Sean Buckley and David Zhang of Emerson. Sean is a life sciences consultant with many years of experience as an end user in the industry. David is director of MES at Emerson and has deep expertise in the area of modeling and scheduling. So without further delay, here is Sean Buckley to start the presentation.
Thank you, everyone. Delighted to be here today. And my goal is to set the scene for David, to provide some context for what he's going to walk you through. I'm not going to go into too much detail. Some of you are probably very familiar with this ATMP space. And more importantly, I want to leave David enough time to walk you through Emerson's RTMS within ATMP. So before we get started, I'll note that when we talk about ATMP versus cell and gene therapy, really we've seen both being used. Traditionally, the term ATMP was maybe more used in Europe, but I don't know that that's necessarily the case anymore. I think generally we see ATMP to be a slightly broader category, which contains cell and gene therapy, and really, is any products that wouldn't fall under the traditional biotech category. So the two are very closely tied together, and until we see a convergence, if at all, then I think, really expect to hit both. So let's jump to the next slide, thanks, David. So a quick look at the market as it is. According to a recent report by the Alliance for Regenerative Medicine, there are 1,195 developers, as you can see on the slide, 2,648 trials ongoing worldwide, 956 unique therapies, and 136 of those are in phase 3. And in fact, these forecasts predicting continued accelerated growth over the next few years, potentially tripling those numbers by 2026. FDA's expectation is the same. Scott Gottlieb back in 2019 predicted, continued increase in these trials, and a much larger set of approvals, at least going through 2025. And in my research, I really haven't seen anything recently suggesting that this growth is going to level off anytime soon. So the industry isn't going away. At this point, we have 20 or 21 cell and gene therapies at least approved in the US right now. So hopefully, as the space continues to grow, we're going to start to see some maturity in the industry, because I think for most, it's still very much in its infancy. Okay, next slide, David, thanks. So as we're seeing the number of trials increase, the number of approved products increase, we're also seeing capacity constraints at the CMOs. Some of this recently may have been due to COVID, either as an impact of the virus or because some of these bigger CMOs have dedicated their resources to COVID vaccines. And unfortunately, we're also seeing some of these problems with raw material suppliers, equipment suppliers, and with the current chip shortages and all these other supply chain issues growing, this could continue to be an issue for a while. But that said, even before COVID, we were seeing 6 to 12-month delays for a lot of the CMOs. And as you see on the slide here, so Bioplan's annual report, which was detailed in a Cell and Gene article referenced, has projected that manufacturing capacity will need to increase significantly. And from their own research, they believe there's about a 5x shortfall, which is obviously creating production bottlenecks, delays in pipeline development. And as a pretty recent example, Bluebird ran into delays when FDA asked to see analytical comparability data between their clinical and their commercial batches. But even Bluebird couldn't turn this around quickly because their CMO, with whom I'm sure they already had a very strong relationship, still had a 6-month wait before they could initiate their runs. And so for companies that can't wait for a year or two for manufacturing, especially some of these smaller companies who have a limited financial runway, we're seeing a lot of companies bringing manufacturing in-house. Oftentimes they do this during their early clinical stages. And so, as well as dealing with all the standard life science considerations when building a GMP suite, you also have to contend with those specific to ATMP. And often with a drug where the manufacturing process is still getting figured out. Okay, thanks, David. Next slide. So we put together some of the challenges we're seeing ourselves or with our customers specific to ATMP. So I'm sure this list could probably be significantly longer. We didn't break them out by autologous or allogeneic, and you may not have experienced all of these, but Or in fact, some of these may not be applicable to your therapy or maybe even your clinical stage. But really, we're seeing a lot of the same concerns, a lot of the same business drivers repeated at ATMP companies of all sizes. And I myself have seen probably all of these at some point in my past. And I'm not going to go through them all today, but as we think about capacity within ATMP, whether it's your own manufacturing or whether you've been lucky enough to find a CMO who can meet your clinical timelines, these examples, each on their own is probably pretty manageable, but together they work to compound the complexity of your manufacturing, as you probably already know. And as you grow your throughput, you're very quickly going to get to a point where you need some kind of intelligent scheduling, and that's exactly what I've seen in my past working on the sponsor side and now with Emerson. As a quick example, if you have an autologous process, single batch per patient, you're going to have to worry about scheduling your lots internally in manufacturing and policy. You're going to have to worry about ensuring sufficient staffing, raw materials, assets for your processing, but also for your testing and your ancillary procedures, as well as working with your external parties like clinical sites, your vendors, maybe your plasmid or vector manufacturing, as well as trying to plan for future downtime, for equipment maintenance, and so on. So it can get complicated quickly. I'll let David go into more detail on how we see scheduling traditionally handled, but I can tell you that in my experience, Excel and ERP, reports, they only go so far. They don't cut it any longer once you start to grow. And I think the higher your required throughput, the more you're going to need an intelligent solution. So with that, hopefully it's a nice segue into David. I'll say thank you again for joining us, and I'll pass you over to David who can give you an introduction to Emerson's RTMS software.
Great. Thanks, John, for the quick introduction there. I think that's a good canvassing of, really high level what the industry is really seeing. A few years ago, we only had a couple approved therapies, especially in the autologous space. And I think this is a good time to really, see how far the industry has really come since that point, and some of the lessons learned of, at least what we've seen in terms of the challenges of really scaling up. So I think as really, you could say an extremity, right, or an extreme case, let's look at the case of autologous, cell therapies, which is really, quite the inverse of, what we'd like to call traditional manufacturing. And by that, I mean, bulk drug substance typically performed in large production fermentation. Okay. So these 6 pieces here really is what we see as the cornerstones of the differences between, let's say, autologous and traditional. And starting from the top there, thinking about really capacity, and safety stocks, right? Those couldn't be any more different. Safety stocks in terms of bulk bio is all about producing as much as you can, simply because the cost of goods is so low relative to the selling price. And in autologous, right, that's bespoke. So there's that concept essentially just goes away. Capacity itself is, much more, you'd say, flexible in traditional manufacturing, right? We have some flexibility in terms of our run rates. We have some flexibility to really absorb any kind of variability in the process, variability in the productivity. And then with autologous, it's essentially, one patient per batch, right? So we think about scaling up, it's more of a scale out process than truly, building larger and larger equipment. I think the driver for all of this is really the service level agreements. When making a generic product, there's really no such thing as a service level agreement, whereas we have commitments to our customers for, a set amount of time from vein to vein, right? And whether that being 20 days, 30 days, or whatever we've chosen, there has to be some sort of commitment that's really going to drive how we shape and, more importantly, how we run and schedule our facilities to meet these SLAs. Looking at the bottom 6 here, this is another, area where, for example, the clinical and commercial batches are very similar in autologous manufacturing. but they become much more different, both in terms of scale and complexity in traditional. So that's something I think we have going for us in the ATM space, is that there is, you could say, much less tech transfer required going from a clinical to a commercial scale. Similarly, the process complexity in the scale out process is, either trivial or very, a lot simpler than a traditional bulk bio facility, especially ones with complexities such as, CIPs or SIPs or hard piped tanks, which really gets down to, you could say the cornerstone of what the difference is here, and that goes to scalability, right? So, we're faced in a pretty unique situation now where we're trying to make commercial drug substance in cell therapy, and now there is a big shortage of labor, right, to perform those activities. And by definition, any type of scale out process is going to require a lot of labor. So, keep these, 6 pieces in mind as we go through this presentation, as we're really going to focus on these when we think about how we actually solve these problems. So, touching back on what we've seen and how the industry has evolved in these few years, the first thing that we're really looking at is, how are people scheduling or optimizing their capacity today? And a lot of it is revolved around simplicity, right? And not essentially optimization. So, we take a look at, let's say, this example, autologous cell therapy, where you have typical patients, batches essentially arriving on certain days. In this process, it's a 9-day process. And what we typically see today is something that is very easy to understand, right? So if you were a scheduler trying to put something together, putting a simple capacity plan, it would look like this, right? And obviously there's some issues with that. One, you can see the equipment is not fully utilized. The throughput is relatively low, right? And there's a lot of white space in here. So this is what you typically see with something that is generated manually. If we take a look at where we want to see the industry go, it's more of an algorithmic generation. So, here is an example of optimizing the previous schedule, right? So using some sort of algorithm to say, hey, what is the best way of putting inpatient lots within, our 2-week planning window? And you can see here, higher equipment utilization, more patients, we're squeezing in another patient in our window, right? And really, if you think about this, we can generate what our theoretical maximum is. There's actually, a whole study behind this, or a whole, you could say, field study behind this. And essentially, we can optimize these manufacturing slots based off of, the demand, right, the type of process, and I think most importantly, the facility layout, right? So depending on those variables, we can generate, totally different optimized, and fully utilized equipment and schedules. And so the theory behind this is really something called the bin packing problem, right? So this is a field of study in operations research, which, in our field, any type of facility that uses this, what's called manufacturing slot methodology, is essentially a bin packing problem. And so the conceptual idea there is, you have these Tetris-like pieces, right? And you want to play Tetris. So you're going to put as many of these, pieces into a fixed window, which is our planning window, as tightly as possible. And the more you can fit in those windows, the, higher utilization and the higher capacity you're going to have. The couple of, you could say, hallmarks of these is that, just like Tetris, right, there's no manipulation of it, right? You can't make a piece bigger or smaller. And similarly, we can't manipulate our patient lot, right? So, each patient is its own lot, right? And, our process is essentially fixed, so we can't essentially extend it, or we can't shorten, right, the length of our batch to accommodate other patients, right? There's also a window of time to start a batch, right? There is, let's say a 72-hour to 96-hour window where we can hold, batches in cold storage. But after that point, we have to start, right? And that goes back to our service level agreements of, how do we ensure vein to vein within a certain period of time? And I think the final thing here is, we can't play catch up, right? So if we miss our window, essentially, that opportunity is lost, right? And we have to, ask for the eighth again, or perhaps get a reshipment of the eighth, right? So there's some pretty large costs here if we don't set up the schedule correctly. The good news is, though, that this is, a well-studied field. So if we take a look at how this looks like on an actual schedule, right? So here, for example, is a screenshot of the product we make, RTMS. And essentially, we think about what does a Tetris piece look like, right? It's essentially a patient lot. And a patient lot represents occupancy on pieces of equipment. So when a patient arrives, we want to make sure that, we have essentially pre-reserved the equipment required in order to guarantee, right, that the patient slots can be processed without scheduling conflicts or without delays, right? So here, for example, we have a certain day fixed process. When the patient arrives, we're going to spend a certain amount of time reserving space on incubators, a certain amount of time based off the day on biosafety cabinets if we need to take samples and we need to transfer to the harvest, and then a certain amount of time on the bioreactor, right? So the trick here is, if we think about a more efficient way of doing this, is not necessarily reserving a certain piece of equipment, right, an exact piece of equipment, for a patient lot, but making sure that that class of equipment is available, right? So, for example, if a patient arrives on a day 3 and they need a biosafety cabinet, well, it doesn't need to be a specific biosafety cabinet, but we do need to be aware that a biosafety cabinet of any type, right, or of any number is available for that patient. And that's how we ensure we don't have any kind of conflicts. So let's take a look at what this looks like in practice. So here, for example, is one patient lot, right? So you can see here, that is one of our Tetris pieces, right? Here's multiple patient lots, okay? And really the part, the reason that we require software is that at some point, the Tetris pieces become a little bit more abstract, right? So we're just reserving equipment on any type of, down here in these boxes, any type of biosafety cabinet or any type of incubator, or just having incubator space per se. And that's one thing that software can help us do. Yeah, so going back to this, it's, in a nutshell, it's equipment selection using software such as RTMS. So we take a step back and we think about, okay, so how do I put all these pieces together, and what type of tools do I need for, at what point in my capacity planning and really facility design. And you can really think of it as essentially a 6-part process. The upper portion represents really the planning, right, the capacity planning, the facility design, and the lower portion is really the facility execution. So what's required to essentially run, right, the facility to meet my capacity needs. So step number 1 is, determine what is the actual maximum, number of lots this facility can produce. And have I designed my facility to meet that? So for example, if we're trying to hit 10,000 patients a year, right? What does my facility to look like? What kind of equipment do I need to choose, right? Based off of that equipment selection, we need to identify the bottlenecks. And that can be either a trivial exercise. For example, if we're choosing equipment such as Miltenyi Prodigy, which is an all-in-one piece of equipment, that makes this problem, moot. Versus if we've chosen a more traditional approach, right, with biosafety cabinets, incubators, centrifuges, et cetera, right, then that might create some bottlenecks elsewhere. And so, identifying what the bottlenecks are and making sure we're addressing the capacity issues that we're hitting within the facility in order to hit our capacity needs. The third thing we want to do is we want to input that equipment constraints, right? And this is just simply equipment constrained at this point. We're not even thinking about labor, into an optimization program. And that's what I was showing earlier, right? In the bin packing problem. How many patients can I fit in based off of my equipment profile into the facility? So that'll essentially give us an upper bound in terms of, hey, how many patient lots can we actually process? And of course, let's match that with the expectations. Once we've done that, now it's all about execution, right? So normalizing the schedule. So, manufacturing loves P&P, planned and predictable. And what we want to do is now apply constraints onto our, facility to say, hey, instead of accepting patients, whenever they arrive, right? Let's try to put together a schedule that, accepts patients on a regular schedule. And that's something that, is going to help manufacturing, which at this point is still primarily labor-intensive process. That will help them get higher levels of schedule adherence. Once we've done that, we need to generate our labor requirements. And, these labor requirements, again, is another efficiency, exercise in efficiency, right? There are certain different groups within our facility, production, quality, warehouse, that will all have different needs and different optimization profiles based off of how we've chosen the schedule. An example of this is, if we front load our schedule, right, that's something that might be more difficult for manufacturing to achieve, but it has a side effect of grouping together assays, which is much more optimal, right, in terms of labor utilization for quality. So there's different trade-offs that we can evaluate based off what we've chosen. And then finally, right, it's connecting essentially the facility into, or connecting the model into other integration sources, right? So connecting them into our chain of custody, chain of identity, connecting them into our demand, and updating essentially our capacity from week to week. So how many people do I need, right, for our expected demand, run that through our schedule, right, and get that type of predictive analysis that we need to essentially staff and run this facility. So when we think about what the capacity essentially of a facility looks like, it really boils down to two things. I talked a little bit about the facility design. What we're seeing today is a lot of modular design, right? So optimize, a single module first, have a certain capacity within that module. And if we want to essentially, increase the number of patient lots we want to process, multiply that module, right? So it's a fairly simple exercise. Within there, some of the more mature customers even try to optimize their modules, right, for all the supporting equipment. So, where are we going to put our modules so that we minimize the amount of media that we need to produce, right? How do we optimize our waste streams? And those all come down to the, the facility design of, what we choose, especially with the equipment that we've chosen. The second piece is really the schedule design. So we've seen here, I think the audience might have heard, hey, this is sort of like, an airplane arrivals board, right, where the arrivals are really the patient lots. And that is true. There's going to be delays when, patient lots are due to arrive and they don't, right? And using software to essentially choose, which lots get processed in what order is going to be key to ensuring that we maximize the throughput. So, in essence, these facilities are very similar to, hotels, and they're also very similar to airports in the sense that we want to maximize the amount of, processing that's done, right, within the facility at a certain amount of time. So really the trade-off here is, we can look at this in terms of really a matrix is, on both sides or both extremities, you have the truly unconstrained schedule design, right, where we're really treating the facility much more like an airport, letting the algorithms, that drive the, when flights leave, or in our case, when we can process patients, be completely in a black box, right? That's going to maximize our capacity, but that's going to make it a little bit more difficult for, people to follow, right? Versus the completely opposite direction, where we have entirely closed systems, right? So we've chosen all-in-one units, and we've structured them in such a way that we only allow for patient lots to arrive at a certain amount of time. That's going to make the process much simpler, but it's also going to significantly lower the capacity, right? So, the ideal location is probably somewhere in between, and there's, of course, trade-offs between costs, expediency, flexibility that we all need to consider, and more importantly, our process itself, right? How does our manufacturing process, does it have a lot of variability in that process? How tolerant is it to patient-to-patient variability? Those are all considerations that we need to consider when designing the facility and, more importantly, designing the schedule. So here, for example, is one thing I was talking about in terms of what does a typical output look like for a commercial facility, right? So here is the target was for a module. Let's say we would do 10 patients per week. Equipment selection was chosen, right? And the schedule was put together in an easy to follow way here, where we're going to accept essentially patients lots only Sunday through Thursday, and we're only going to accept them in certain windows of time, right? So during the 6 a.m. to 3 p.m. time frame, let's say within an hour, that's how robust we've designed the system in order to handle patients and meet essentially 10 patients per week. Now, that is more or less guaranteed. And the question that was posed by the site essentially was, how many people do we need to run this facility, right? So the step number one is to figure out what is, how many people do I need to run this facility in order to guarantee that we won't have any production delays or shortages, and that's represented in the chart you see to the right. So very intuitively, because we're not processing things on Friday and Saturday, right, there's going to be less of a demand of people on essentially the weekends, okay? So this was the insurance policy. Now, if we think about how we can essentially get a more efficient way of doing this, right? So obviously not very cost effective to staff to the maximum. We can now put in, a scenario planning, right? So let's put in scenarios in terms of, how often patient lots arrive on time. Let's put in scenarios that incorporate the variability in the process. So if we have a process that can range anywhere from, let's say, 7 to 9 days, well, we need to perform what-if analysis on top of that to really get an idea of what the true requirements are, right? So, the majority of patient lots land between 7 and 8 days, right? That's going to create a different demand profile of FTEs required if they're uniformly distributed between, let's say, 7 and 9 days. In this situation, you can see that, when we ran the simulations, there is actually a peak staffing, right, based off of the schedule that was chosen on Wednesday and Thursday, right? So this gives us unique insight to say, hey, during these times of day, right, we can have that as a shift overlap day, Wednesdays and Thursdays, and the rest can be at a lower staffing level. And of course, what these charts show you is, the amount of risk the site is willing to take based off of what the demand looks like, right? So, we can either staff to the maximum, incur a heavier cost, or we can do a trade-off. Let's say, staff to 95% of the requirement, right? And every 5%, right? Essentially the Pareto rule, whatnot, right? Is something that we'll just need to deal with or build some sort of contingency for. One of the big outputs here, that I touched on earlier was that's just manufacturing, right? So each one of these essentially schedules or commitments will also have requirements for other areas, and these other areas can definitely they're not trivial, right? So quality, for example, right, is something that is very much high in demand. I think just in general, training people is very much high in demand. And more importantly, incurring costs that, overtime costs, right, is a big issue for some of these sites. So not only do we have a labor shortage and a skill shortage, right, that becomes even more scarce during odd hours. So there is a desire, for example, to not only minimize the amount of, labor hours required for these other groups, right, but it's also to minimize the amount of time they actually work. So can they go home before midnight is actually a question that we hear quite often. And this is just a sample, right? There's many more issues that we have here around like maintenance as well, document control. These are all things that add up naturally from a labor-intensive process. So what's the solution to this? And this is really where I would say the big shift is when it comes to these scale-out processes, that they become much more focused around people's qualifications, availability, right, and their training. So the key piece here is to really take a look at and say, hey, not only do we need to make sure that the equipment is available and ready, but we also have the people. So that has been our primary focus, is assigning people to various tasks, right? Managing people's availability, when we have people go on vacation or if they want to do training, right? That will reduce our capacity, And in fact, even training people, right, reduces the capacity of the facility, because you have to take those trainers out from the manufacturing floor, which by definition is going to reduce our capacity. So managing this problem, and by definition, managing not only our commitments, but the cost of goods for our facility and for our batch, is the key challenge moving forward as we scale up in this space. So to wrap this all up, there's really two areas or two key things that we're really trying to look at here. As we're preparing for the commercialization, right, on essentially the capacity planning, the right tool to use here is essentially an optimizer, right? And that we want to run scenarios, we want to help design our facility, fix our schedules, right? Fix what we're calling our essentially standard work, right? To really make sure that when we design our facility with the intended capacity, that we can actually meet that capacity. And once that's happened, right, the big notion there will be execution. And using a tool set such as RTMS will help us guarantee that execution, right? And ensure that, we have the right people, the shift schedules are there, and even being able to change shift schedules, inputting facility changes, right? And helping with the ramp up, right? Helping with, what do the trade-offs look like as I ramp up my, production, and as I take people off to train more people, right? What should my, supply chain forecast look like? And what kind of commitments can we guarantee, our customers?
Once again, Sean and David, thank you very much for your presentations today. And to all the participants, thanks for joining us.